Alright, well we're going to talk about knee replacements today. We're going to talk first about conservative management and then talk about specific types of knee replacement.
Oh, it's on, but you have to do your mouth. Okay, sorry.
Alright, so we're going to talk about knee replacement. First we're going to talk about conservative management, and then the different types of knee replacements and ultimately advances that have occurred recently in knee replacement and how they may affect outcomes. Well, anyway, we'll go on. The first part of the talk is about anatomy. And ultimately, osteoarthritis is wear and tear of the cartilage. I always analogize it to just wearing the treads out on your tires. It's just wear and tear. There's a genetic component to it in that some people are more predisposed to it than others. But it's nothing. Next slide. We have a good slide. This is just going over the anatomy of the knee joints. In particular, we're looking at the articular cartilage, but I talked to a gentleman earlier about meniscal tears, ligament tears. These are all associated problems in the knees, and the ligaments and the meniscus can wear out as part of the degenerative process. But ultimately, what we're looking at is osteoarticular wear. Next slide. This is a good picture of osteoarticular wear in the knee. Again, the white is the cartilage. You can see where it's rubbed down to bone. Great for osteoarthritis is just when the cartilage is completely gone and you have bone rubbing on bone. The other type of arthritis that we don't see too much in the knees is rheumatoid arthritis. This typically affects more the small joints of the hands and wrists. Sometimes you'll see it in the knee joint. It's an inflammatory arthropathy where literally your own cells are eroding your cartilage. So, as we talked about, wear and tear osteoarthritis is simply the wearing out of the cartilage. It happens over time. There is a genetic component to it. It does run in families, but it's also environmental in that the more you load the knee, the faster it will wear out. Symptoms. What we do clinically is we can differentiate the symptoms of arthritis versus meniscal pathology based on the type of pain you're having. If a patient comes in and says, I have sharp stabby pain, or pain in certain positions, like the gentleman I talked to earlier, that's more consistent with meniscal pathology. That's something that can typically be treated with an arthroscopy. Arthritis manifests as a dull, achy pain, usually significant stiffness in the morning or stiffness when you get up from the chair for having sat for long periods of time. It progresses to a chronic dull, achy pain, but it doesn't have a mechanical component to it per se. It doesn't really change with position of standing or positioning of the knee. It's just kind of constantly there. Physical exam, it's pretty easy. Patients will have diffuse swelling in the knee. They'll actually have what we call crepitus, which is a crunching sensation when they range the knee. 90% of patients with arthritis have pain on the inside of the knee. We call the medial compartment. You'll have tenderness right along the joint line. So it's a pretty characteristic exam. If you come into the office, we usually get imaging studies. I'll have some x-rays later to show of actual arthritis. This is an actual knee replacement. So first we're going to talk about medical management. And I'm sure you've all heard that there's a big problem in our country of obesity. The average person is 20 to 40 pounds overweight. There have been several studies done which show that increased weight will cause the cartilage in your knees to wear out faster. Again, I always tell people it's like driving a pickup truck. The more you load in the pickup truck, the faster your tires are going to wear out. The harder you drive the truck, the faster your tires are going to wear out. Well, the same is true for cartilage. It wears out based on load put on it, how hard you're walking, and how much you're walking. The initial conservative management is just to do some exercise. We know that strengthening the muscles around the knee will alleviate the pain to a degree. But the primary exercise that helps is aerobic conditioning. If you do something aerobic, get your heart rate up 30 to 45 minutes a day, we know that will decrease your perception of the pain. It doesn't change the fact that you have arthritis, but you won't feel the pain as much. And the constant motion tends to make the joints move easier, and when they move easier, you have and perceive less pain. The next step is analgesics. In many cases, people are taking anti-inflammatories. There are obviously some downsides to that. Some of the newer medications, newer anti-inflammatories, are what we call the COX-2 inhibitors. These are medications specifically designed for chronic use. If you take ibuprofen or you take naproxen, the problem is taking these chronically can erode the gastric mucosa in your stomach and can lead to ulcers. And the ulcers in turn can lead to kind of bleeding. And in many cases, the patients aren't aware they're bleeding. and they can get anemia. So the problem is if you take ibuprofen or naproxen and you've taken it for 6 months or a year, you have to, even if it's working, you have to follow up with your primary care physician so they can monitor these side effects. The COX-2 inhibitors, the COX-2 inhibitors are specific because they don't really cause that much GI upset, and those are medications that are designed to take every day for years. The other medication that a lot of people take orally is glucosamine and chondroitin sulfate. You'll see this in the stores, it's osteobioflex or shark cartilage or these other things. The efficacy of these is really not that clear. They've done a bunch of large multi-blind, double-blind studies which show that it does have a placebo effect. So as such, when patients come into the office, it's always difficult for me to tell them that it may not work because in many cases, 20 to 30% of the patients are noticing improvement with these things. There is a placebo effect. If they give patients a sugar pill in a study, they also get better. So it's always difficult to tell people, well, these may not work. What we do once you come to the office and you've had anti-inflammatories or you've taken glucosamine and chondroitin sulfate, it's not work. The first step is typically a cortisone injection. Cortisone is effective in 80 to 90% of the patients that we inject with who have osteoarthritis. So typically we'll work you up, do an exam, get an x-ray. If we diagnose you with osteoarthritis, you have definitive osteoarthritis. Above and beyond the anti-inflammatories and the other oral medications, the first step is a cortisone injection. They normally are effective. The problem is they don't always last that long. When I see a patient, I'll tell a patient that the cortisone may last from anywhere from 2 days to 2 years. It's hard to tell. But on average, we're lucky to get 2 to 6 months with a cortisone injection. And the good news, if we do get that much relief, we can give you about 3 injections a year. But they tend to be of diminishing return, which means that you get 6 months with the first one, 4 months with the second one, and you're down to 2 months with the third one. So that's when we move on to the next step. Hyaluronic acid injections. Now, if we get good relief but short term with cortisone injections, we usually move on to products called Synvisc or Orthovisc or Suparts, and you may have seen ads for these. These have a different mechanism of action. Cortisone is a very potent anti-inflammatory. So we inject that, it takes the inflammation down, patients feel great. But if you haven't solved the problem, which is bone rubbing on bone, the problem just comes right back. What the Synvisc or the hyaluronic acid does is it effectively acts as a lubricant. Hyaluronic acid is a core component, it's a large molecule in cartilage. So what this is it's a huge proteoglycan molecule. We inject it in. It basically binds to the cartilage and acts as a lubricant, giving it a viscous layer. It's not quite as efficacious or pain relieving as cortisone is. However, it tends to last a lot longer. So I'll routinely tell a patient if you got 90% relief for say 2 weeks with cortisone, you should get about 50 to 60% relief with hyaluronic acid for between 6 months and a year. We typically can only inject this twice a year as insurance will only cover it every 6 months. There's some new things on the horizon which could prove to be good, maybe not. One you've probably heard about is PRP injections or platelet-rich plasma. This is where they take your blood, they spin it down, they concentrate the plasma cells, and they re-inject it. The idea is that the plasma cells are the cells that will heal the tissues. And the idea being if we put it in, it'll heal your tissue. This has proved very effective in certain tendinopathies. Some of you may follow golf. Tiger Woods had it in his Achilles tendon. It worked pretty well. There's a guy on TV, I don't know if you watch the stock program, that Kramer guy. He had a tennis elbow. He had an injection and that helped as well. It's been proven effective in Achilles tendonitis and tennis elbow, but has not been proven very effective in the treatment of arthritis. In fact, the American Academy of Orthopedic Surgeons does not recommend its use with respect to arthritis. But there are people out there who are trying the injection on hope that it will work.
The braces.
Stem cells. So the new thing that's coming out that may actually prove efficacious is stem cells. There are some practices in San Diego that are injecting stem cells in these. Studies are still kind of cursory, so we don't know if this will or will not work. I know our practice is contemplating doing stem cell injections in these. It's a little too early to tell, but this is something that is becoming clinically available. There are 2 different ways to take the stem cells. One is they do a bone marrow aspirate, so they'll take a bone marrow aspirate from the back of the pelvis, spin it down, grow the stem cells, re-inject it in the knee. The other is the stem cell precursors can actually be taken from fat cells. But it's a 2-stage procedure. You have to take the cells, grow the cells, and then re-inject them. Knee braces. Knee braces do work. They are very effective. These are called unloader knee braces, and you can't really see on the brace that well. But what these tend to do is if you have arthritis on the inside of the knee, there's a turnbuckle that pushes on the outside of the knee and literally unloads the knee. And I found these to be very effective. They do work, and nobody wears them. I have a couple male patients who do wear them, but these are big, bulky braces. These are what you see the offensive linemen wearing playing football. And nobody wears them, but they do work. So if you have arthritis and you're contemplating a brace, they do work. They work very well. Well, ladies don't like them because they're big, bulky braces, and they can't wear them under their pants. And I would say 50% of the men that I fit them with will say, yeah, it works, I do wear it, I'll wear it when I go hiking or something, but they don't wear it all the time. So, I think I guess I haven't explored specifically what the problem is, but they just don't wear them all the time. So when they're out walking, if they go to Disneyland or they go hiking or something, they will wear it. They do say it does help. But I guess it's it's problematic putting it on. I mean, it takes them probably 5 to 10 minutes to put it on, 5 to 10 minutes to take it off. Yeah?
Do you have to have them custom made or
Yes.
something you buy?
Oh yeah, I'm sorry. These are custom made braces. So you're actually measured for them because they have to get the fulcrum. They have to measure the fulcrum and they have to measure the pressure, the turnbuckle device so that they get adequate
Do
pressure.
you have any idea insurance on something?
Yeah, insurance typically will cover them, but they're not cheap. They can run between $8 to $1,200.
Simple ones.
Well, the simple ones you can buy regular brake braces, but they're not the turnbuckle ones. These have, again, I don't have a good picture of them, but they have a device. Best analogy is a turnbuckle. It's a little screw device, and you put the brace on. And if your arthritis is on the inside of the knee, you turn this thing, and it puts pressure on the outside of the knee, so they're kind of adjustable. But literally, what it's doing is it's pushing your knee into a position to unload the part of the knee that's got articular damage. Yes?
I understand that would be progressive because the arthritis has to build up as it's going along. What are the early symptoms so that you can catch it in the early stage rather than waiting for it to go beyond, where you would have major surgery?
Well, the early symptoms are pain. Arthritis, well, it's typically described as a chronic dull aching pain. I mean, I think most of us initially manifest arthritis as stiffness. I recently turned 50. I get up in the morning, I'm stiff. The first stage of arthritis is just an inherent stiffness in your joint. You get fibrination in the cartilage gets little cracks in it. It doesn't move. You get a little bit of crunching. A lot of times in knee arthritis, people will first get crepitus in their kneecap. They'll notice pain behind their patella when they're going up and down stairs. That's typically the first part of the knee to wear out. And you get a little bit of crunching, and in most cases, patients don't notice pain initially. I mean, we don't really, as orthopedists, we don't start treating it until it's painful, but the first signs are probably just a crunching in the knee going up and down stairs or squatting.
Or you hear that clicking type crunch?
Well,
I
I think it's the best analogy of crunching. It's a crunching sound.
Crunching.
Okay, at that stage, what could you do to prevent it from going worse?
Well, I think that's the take-home message here. There's not much you can do to prevent it. That's why, again, I use the analogy of wearing the treads out on your tires. If you're going to drive your car, the treads are going to wear out. Now, the only thing you could hypothetically do to decrease that is not walk or not climb stairs. So if you engage in some kind of activity, say you're on a stair climber every day, well, that's going to wear out the back of the patella faster than not doing it. Of course, there are obviously obvious benefits to being on a stair climber. But the problem is that you're going to wear out the back of the patella.
How long do you estimate before the stem cell therapy will be available in a recognized medical facility? How long do you think it will be down the road?
It's available in San Diego at some facilities now.
I'm talking
Now,
about
whether they're recognized,
yeah, that's
that's your
what I'm talking
definition.
about.
Huh?
I'm talking about a recognized medical, a tri-city or Scripps or somebody like that.
Well, currently it's an available therapy that is not covered by insurance. Okay? I don't think it's going to become commonplace in a Scripps or a Sharp or a UCSD until it's covered by insurance, and that may not ever prove to be the case. I mean, in order for insurance to cover a treatment, it has to usually have an 80 to 85% efficacy. which means it has to give good to excellent results 80 to 85% of the time. Synvisc is kind of a 50, 60%. Right now, the hyaluronic acid injections, some of the insurance companies are balking and paying for that because it doesn't really measure up to their typical efficacy. To answer your question, I'm not sure stem cells will ever be in a mainstream type of situation. I don't know that they'll ever be covered by insurance. Okay, so back to the other things you can do are obviously canes and walkers. So when all those things fail, we move on to joint replacements. Joint replacement is essentially resurfacing. I mean, again, I get back to the tire analogy. If your tires wear out, you resurface them. So that's basically what joint replacement is. There are 3 different types of joint replacement. The total knee replacement replaces essentially the whole joint. There's also what's called the uni-compartmental knee replacement. Now, this is a little bit less invasive. It's typically for people who have isolated arthritis on the inside or the outside of the knee, and the rest of the knee is okay. The third type is patella-femoral replacement. Now, we talked about the patella-femoral plane going up and down the stairs. Some people come in with very severe isolated patella-femoral arthritis, so it's only arthritis behind the kneecap. So when you see your doctor, they'll talk to you, they'll look at your x-rays, they'll try to decide where your arthritis is, whether it's in one compartment, the patella-femoral joint, or the whole knee, and what's the best option for you. These are just some graphs. I mean, I think it's pretty obvious that the population's aging and the number of knee and hip replacements are going to go up drastically in the future. Yes?
What's the oldest patient that you've done a knee replacement on?
I think we've done several on 90-year-olds. Octogenarians are pretty commonplace these days. I always tell patients, you'll have patients come in their early 80s, and they're, well, I'm too old to get a knee replacement. Well, this is something to think about. Statistically, in this day and age, if you make the age of 82, you have no active coronary artery disease or heart conditions, and you have no active cancer, you have a 75% chance of living to 100. So to be 80 in your early 80s and be suffering with knee arthritis, if you're otherwise healthy, it's probably, just because you think, oh, I'm too old to do this, probably isn't appropriate anymore, because you've got quite a haul ahead of you, and to suffer for what could be 20 years doesn't make a lot of sense. Particularly because your health will in part deteriorate because you're not active and you're having pain. So we'll first talk about a total knee replacement, then we'll go on to uni-compartmentals and patella-femoral arthroplasties. But a total knee replacement effectively covers the whole joint. There's a femoral component which goes over the, let's go to the next slide. A femoral component which goes over the distal femur, and a tibial component which goes on the top of the tibia, and essentially resecting the cartilage. We basically trim the bone, and we put a metal and plastic component on where we trim the cartilage out. And then there's also, I don't have a big slide of this, but there's a patellar component behind the patella. You don't always have to resurface the patella. I think most people do, but we usually take the cartilage off the back of the patella and put a piece of plastic on that too. So this is a picture of a knee replacement, and I think you can kind of see, basically you make a cut across here, and a cut across here. This is where the cartilage is in the space. So cartilage doesn't show up on an x-ray. So the way we judge somebody with arthritis is how much space they have. When you have arthritis, there is no space. The bone is rubbing on the bone. But essentially the knee replacement is to cut this, and resurface it. So here's another picture, same idea. You can see the patella component in the middle that goes on the end of the femur. I'm sorry, the femoral component goes on the end of the femur. The tibial component is a tray that goes on top of the tibia. And then there's a polyethylene that goes, typically it either locks into the tibial tray, or as you'll see, I think on the next slide, there's also a type of knee called rotating bearing knee. Now this is an interesting type of knee because the polyethylene, the plastic, the white in the middle, isn't fixed. It actually rotates on an axis through that central thing. So as you walk, it actually moves with you. And there are pros and cons to either one, and it's kind of a philosophical difference. So now we're going to talk about uni-compartmentals. Uni-compartmentals are knees where we're only resurfacing the inside of the knee. Where we only resurface the inside of the knee. Okay, So it's only the inside of the knee is resurfaced there. The outside of the knee and the patella-femoral joint up here where the patella would track, we leave alone. This is a procedure that can only be done on patients who have isolated uni-compartment arthritis. Okay? They're typically younger patients. If a patient comes in as a candidate for this, we have a lengthy discussion with them. Because the problem is, if you put this in, this will work great. But the problem is you'll wear out that part of your knee, and you'll wear out behind the kneecap with time. So the problem is when that part of your knee wears out, then you're going to have to come back and have total. Okay?
Has anybody got a partial and not have to get additional help? Are there individuals that seem to manage just with a partial?
Yes, I'm sure there are. Okay, so here's an example of a uni-compartmental. Again, arthritis on the inside of the knee. We resurface it the same way we would do a total knee, but just that one inside part, leaving the outside cartilage. That's what it looks like on X-ray. And you can again see the cartilage mantle looks pretty good here. So in many cases, these patients, we can judge the arthritis on X-ray, but many of these patients have already had a knee arthroscopy, so we've literally been in the knee with a camera, and we know that there's no arthritis on the outside of the knee line. So the third type of knee is a patella-femoral replacement. Again, this is isolated articular damage or arthritis behind the kneecap. Again, it tends to be younger patients. They haven't developed arthritis in the main part of their knee. And we just resurface the patella-femoral joint. Okay? So this is a piece of metal right here. You can see the patella right there, the kneecap. And the kneecap has a piece of plastic on the back of it. So the only articulation we're replacing is the patella-femoral compartment. And we're leaving the main joint intact. Yes?
How sure are you when you go in that the one part of the knee is healthy and the other part is not healthy? Do scans always show that? Or does it show more once you get in? You may say, I'm not sure what you say. You say this man needs a full one or the part is okay.
Well, that's a good question. There are a number of things. I mean, obviously we take x-rays on everybody. Typically, if you have patella-femoral arthritis, we'll start with that, for example. Normally, we're going to have treated you with injections, and normally before we even get to this stage, we will have treated you with an arthroscopy, because the majority of patients with patella-femoral arthritis, isolated patella-femoral arthritis, we can treat effectively with an arthroscopy. Now, arthroscopy is an outpatient procedure. It's a knee scope, a couple puncture wounds. We go clean out the cartilage. The patella-femoral joint doesn't take the load that the regular knee joint does. So in many cases, you can treat it effectively with an arthroscopy. So to answer your question, in most cases where we're doing this, we've already been in the knee and we've got pictures of the patella-femoral joint. We also have pictures of the rest of the joint to know that it's not damaged. Okay.
I was outside, and there must have been about 12 people, and each one of them had a different cell phone. And I'm wondering how many different types of kneecaps are there, and what is the advantage, and who makes the choice as to what kneecap the patient is supposed to have?
In terms of the type of prosthesis?
I'm sure there's more than one manufacturer.
Yes, there are several types. I think that ultimately depends on your surgeon. I mean, it depends on who you go see. Certainly, I have partners that are very set in their ways. They use one system and one system only. You know, I use several systems. So it's ironic. We have a patient, there's a rep in the back. I had a patient come in that had a certain implant that I haven't used in years. Just the other day, he wanted the same implant put in. I have no qualms about putting the same implant in. It ultimately comes down to the familiarity of your surgeon with whatever you want or what you feel comfortable with. You know, we live in a day and age where there's a lot of advertising on these joint replacements. And the problem is you may see an ad that says, oh, the Stryker hip's the best hip in the world, and you go into your surgeon and you say, I want a Stryker hip. Well, ultimately you want whatever he's familiar with and what he's used to using. Now I have to admit, since I've been doing this, all the implants are becoming very, very similar. And to implant one knee versus another knee, there's not a big drastic difference between the technique to implant them that there used to be just 10 to 15 years ago.
Do they use any kind of materials that may be different? For example, like some may be made out of metal, some may be made out of plastic or porcelain or ceramics, or anything along that line?
I got that coming up. I'm going to get to that.
Give me an idea of the recovery time between the partial and the full. I mean, I'm an active tennis player, so would I be able to get on a tennis court in half the time with a partial versus a full? Or give me an idea on that.
Well, the best answer to recovery is the recovery is up to you. Okay, and in all the studies that have ever been done on recovery from total joints, whether it's uni-compartmentals or total knees, it's the physical stamina and condition of the patient going into the procedure that determines how quickly they come out of the procedure. So if you have an active, relatively younger tennis player, I would expect him to recover significantly faster than, say, an 80-year-old person who didn't play tennis. But really, it has nothing, it does in part, and we'll talk about the differences in the procedure, but really, ultimately, your recovery speed is based on you and your condition going into the procedure. Now, with respect to the difference between the unicompartmental and the total, the incision for the unicompartmental is smaller. Most unicompartmentals that we're doing in our group are being done outpatient. So the patients go home the same day. We have a surgery center off of the highway on Palmer Road, and they're doing 3 to 4 unicompartmentals a week, and the patients go home the same day. Is that really based on the fact that recovery is significantly faster? No, they're doing a select group of patients in an outpatient facility. They're younger, they're healthier, and they know they can go home faster. So again, it gets back to the fact that the patients are younger and healthier, they're going home faster. You know, if we did an 80-year-old person, we may do that at the hospital just because there's some medical implications, and the patient may not go home in a day or two. But that's based more on age and, again, the physical condition that's down and going in. But ultimately, you are correct. The unicompartmental, you will recover from faster. The other advantage of the unicompartmental, just so, since you mentioned tennis, is that you're preserving the ligaments. Okay, I don't have a good slide of this, but I think you can understand that you have an ACL and a PCL and a lot of ligaments. The advantage of the unicompartmental knee is you're not taking any of the ligaments. When we do a total knee arthroplasty, we cut the ACL. In some cases, some of the surgeons cut the PCL. So there's an inherent instability in the knee. So it's going to be harder for you to play tennis on a total knee arthroplasty than it would on a unicompartmental. We don't tend to restrict people with unicompartmental knees, in part because we tell them right up front, you're going to get arthritis in the rest of your knee, and you may need a total knee down the road anyway. Okay? But the other reason is because they still have their ligaments intact. And mechanically, that knee is very, very similar to the knee that you went in with, whereas a total knee is different. I think we'll get to that a little bit. Does that answer your question? Yes?
Did you mention something about injections? And are there different types? And how about the procedure where they, like, supposedly, I think, do it with an X-ray so they know where they're putting the injections?
Yes, we'll do them with ultrasounds. You know, we were talking about this yesterday in the office. I mean, I probably inject personally about 15 knees a day. I think there are some joints where you need to have an ultrasound guidance to inject the joints. I'm personally not convinced that the knee is one of them. Knees are pretty easy to inject, but there are certainly some people that can use an ultrasound to facilitate the injection.
And you use different types of fillers?
Yeah, we had kind of gone through that earlier. Talked about cortisone injections, hyaluronic acid injections, or Synvis. Now, these again are the two things that insurance typically covers. And then we kind of got a little fringy with PRP injections. Those again are not covered by insurance. Those typically patients pay for. American Academy of Orthopedic Surgeons does not advocate these in patients with arthritis. They're very effective at tendinopathies. So again, if you have Achilles tendonitis or tennis elbow, this is a good thing to consider. And the last thing is stem cells. Now, stem cells, I know, are available. There are several practitioners in San Diego County who are doing them. Our practice is contemplating doing them. We may be up and running in 3 or 4 months. But again, these two, PRP and stem cells, are not covered by insurance. That's something, unfortunately, you have to pay for. And in part because we don't, certainly with stem cells, we don't know how effective they are.
With the hyaluronic acid contained in the pill form as well, right? How do you feel about
Right,
that?
that's the glucosamine and chondroitin. I talked about that. And when they've done large double-blind studies on that, it has a placebo effect, but doesn't prove to be any more efficacious than a sugar pill. Well, I think if you think about this, I mean, these proteoglycans the cartilage is made out of huge molecules. Okay? When you eat anything, your body breaks it down. And what we know that your body will break these down. They've done tracer studies on proteoglycans when you ingest these, and they're broken down to core components. And the body does not reassemble them in your joint. So, you know, biochemically, it doesn't make sense why it would work, because we know your digestive system's going to break this down. And these are huge molecules. These aren't vitamins, which are little sterile molecules. These are big, huge molecules, which are broken down by the time they get in the bloodstream. Okay, so advances. So we talked about the 3 types of knee replacements. Now, what's happened recently that makes the knee replacements better? Well, we're doing more minimally invasive approaches. We can put total knee replacement in now through about a 4 or 5 inch incision. The uni-compartmentals are even smaller. The implants are better, but ultimately this comes down to better materials. We had talked about that a little bit earlier. I'm going to go on that again, but we're using ceramics now. We're using vitamin E polyethylenes, which I'll have some pictures of. The materials last longer. There's a knee. We always told patients that if you put a knee in, it would probably last 10 to 15 years. And we would tell patients, oh, you're too young for a total knee because we're worried that if you live into your 80s, we'll have to revise the knee, and we don't want to do that. So we would inject people and treat them conservatively until we felt comfortable doing the total knee. That age limitation is getting less and less specific. And that's in part because one of the knees the FDA has approved as a 30-year knee. The wear characteristics on these are so great when they test them in the lab that they don't think they'll wear out for 30 years. And this is probably only going to get better. So again, it used to be 65 was our cutoff to start doing knees. It's down to 55, and we're even fudging that a little bit lower now because we think we have the components that will literally last 30 to 40 years. Just going back to the slide. So the other big advantage, and this is a recent development in the last 2 years, is the pain management. A lot of the anesthesiologists are doing blocks, and the blocks give complete pain relief for about 2 days. So the patients are up, they're recovering very quickly. We're mobilizing patients literally 2 hours after surgeries now. As we talked about, they're doing these outpatients. They'll get the patients up walking out the door in 2 to 3 hours. And that's in part due to the pain management. Tranexamic acid is something we're giving very, very rarely. We ever transfuse a patient anymore. Tranexamic acid causes the blood decreases the bleeding significantly post-operatively, and so it used to be pretty commonplace to give transfusions and joint replacement. We don't do that anymore. Computer navigation, we'll talk about that, and then ultimately faster rehab. We're mobilizing patients faster because they have no pain, and they're getting out of the hospital quite a bit faster. I'm kind of behind, so this is another technique that Alchematis. We have special equipment we use in surgery to get better hemostasis, so there's less blood loss. Computer-assisted surgery. Go on to that. What this is one of the techniques to decrease the incision size is to use custom cutting blocks. So what we do is we get an MRI of your knee, we find what the anatomy looks like. The computer generates actual cutting blocks for your knee. They're specific to your knee. That way we can put them on in smaller incisions, just pin them and cut the bone without having to make a larger incision using the typical guides that we always use. This again, we have computer navigation systems so we can get the placement of the prosthesis in perfect mechanical position so it won't wear out. Gender-specific implants, these have kind of fallen out of favor, but typically there have been, they found out that the trochlear notch and certain anatomic characteristics in a female knee is different than a male knee, so they've made specific implants for females versus males. We have a Blue Belt at Tri-City Medical Center. This is again a robot where we take pictures of your knee once we get in there. The robot puts them in the computer, gives us a picture, and actually helps us make the cuts more accurately so the component placement is optimized. Vitamin E polys, we talked about the materials. One of the big developments is they're putting a vitamin E in the polyethylenes. They found that this significantly improves the wear characteristic. The main problem in a knee replacement and the wear over time is the plastic. The plastics in the past, and I'm old enough to remember this, they wore out pretty quickly. That was the limitation. When we said 10 to 15 years, it's because the plastic would fail, and we'd have to go put a new plastic in and revise the knee. And what happens is when the plastic fails, it puts out all this particulate matter, and the particulate matter causes inflammation and causes the components to loosen. So what we revised knees for was loosening due to polyethylene wear. The polyethylenes now are significantly better than they were, and that's why the knees can last longer. Okay, this is just a graph showing you the differences in the polyethylene wear. So this is a very common Zimmer knee that people were using regularly. This is that new vitamin E knee, and you can see that the wear characteristics over millions and millions of cycles is significantly less than the old type of knee joint. So once you've decided for surgery, I'll go through this pretty quickly. As we talked about earlier, your recovery is going to be based on your condition going in. So the better condition you're in, the thinner you are, the faster you will recover from surgery. And when I do a knee replacement, I always go in the first day, and I say, my part's over, your part's begun. Because really the recovery is based on the patient at that stage.
What's the length of time of recovery?
It's going to differ from
vulnerable
person.
situation.
It's going to differ from person to person. I'll tell you a funny story. real quick.
Worst case.
Okay, but let me tell you a funny story. I always like to tell this story. So I did bilateral total knees on 2 patients the same day. A real quick story. One was a 50-year-old guy, long blonde hair, he'd been a bodybuilder, great shape. The other guy was 87 years old. Okay? Long story short, the 87-year-old guy recovers significantly faster. In 2 days, he went home. Okay? Even the therapist, like, we've never seen bilateral total knees go home that quickly. Okay? But the point is, it's all in your head. Your recovery is based on how hard you worked postoperatively and the physical condition that you had coming in. Okay? Now, long story short, I was amazed. I went in to talk to this guy after surgery. Turns out he and his wife had both survived concentration camps. So, recovering from a total knee is nothing.
My wife's been thinking 3 months. Right? Recovery time.
Yeah, we usually tell people the complete recovery from a total knee arthroplasty is going to be about 2 months. If people come in and say, how long until I go back to work, it's usually about 2 months. But again, you'll see patients, this is an interesting procedure because you'll see patients really fool you. Patients you don't think you're going to do well, do really well. Patients you think will get through it really quickly, don't.
So that person in recovery needs a lot of help at home, is that right?
Again, it's patient dependent. It's patient dependent. We're sending patients home the same day from some of these doing totals or doing some work.
Yeah, that's what I'm thinking of.
I have 2 friends. One had the operation done on both knees, had never a problem. The other one had the operation done on both knees, never got well. Oh.
Right. It's, you know.
You never know what you're going to get.
Can you replace meniscus, or is there? I had some meniscus removed, and now I'm getting some pain.
Yes, you can do meniscal repairs, but again, that's kind of a whole different talk, and I'm running out of time.
It's knee surgery.
Yeah, it is. You're right. Okay. So just quickly, again, recovery. We talked about the recovery is different for different people. You have to prepare for that. Obviously, the risks associated with any surgery, the main one with a total knee arthroplasty is a blood clot. And we put you on prophylactic blood thinners post-operatively, typically for 10 days. But again, as the procedures have been more sophisticated, I've seen, when I first started, we were doing 3 months. Now we're down to 10 days. And then just the post-surgery protocols. Again, anticoagulation therapy we talked about. We're not using CPMs, which are the machines anymore, because studies have shown those don't really help. We take catheters out almost immediately. Then the recovery in the hospital is significantly faster than it used to be. Very rarely are we doing transfusions, okay? With this transaminatic acid, we very rarely have to transfuse it. And then we talked about the femoral nerve blocks and the good pain relief post-operatively. Okay, and physical therapy. Results of knee replacement, this is the highest patient satisfaction procedure we do in orthopedics. 90 to 95% good, excellent results. Okay? So it usually works, most cases. And this is an example of that. Okay, so this is a picture of a knee. I was going to show you. So you can see the arthritic knee where the joint space is gone. And then this is after a knee replacement. And you can see how the alignment has been improved. So that's the result of the knee replacement. Thank you.
Thank you for